Mute all. Okay. Okay. Can you hear me still? Oh, you can. Uh, this this talk is dedicated to Dr. Kakala Subbarao and Dr. Chan. I don't need any introduction. I don't need to give any introduction to Dr. Kakala Subbarao. Dr. Chan is a radiologist from MD Anderson Cancer Center. Both of them have influenced me and imparted critical thinking into image interpretation, which is key. So majority of the content I'm presenting today in this lecture has been published, it's just been published in Japanese Journal of Radiology as a two-part articles. One is about temporal evolution. The second one, so basically first one is an illustrative review, and the second one is using that approach to propose a new subcategorization of metastatic disease. So coming to the temporal evolution of metastatic disease, or so the reason I'm trying to talk about this, like I've got interested in this, is because like it always surprised me. Like I was always interested in understanding how the tumor that I'm seeing on the current study, how did it reach there, and where will it go next? So that is the approach that I want you to. I'm giving you in this lecture. And the established literature currently mostly discusses about differential diagnosis at diagnosis, baseline studies, or response assessment. Beyond radiology literature, clinical studies also talk mostly about patterns of spread of disease, but they do not go beyond the disease at presentation or first treatment. There's not much literature about how the tumor spreads over a period of time. But we are at a time point where the treatment paradigms have improved and people with metastatic disease are living longer. So this is an attempt to understand how the tumor spreads over a period of time. And this is a basic knowledge. I don't need to tell anybody, but these are the basic pathways how the tumor spreads. It directly infiltrates into the adjacent tissues and organs. Sometimes it can spill into the adjacent pleural, peritoneal, or CSF spaces. They spread through lymphatics, hematogenously, and the tumor can also spread by any combination of these routes. So here I'm going to show some examples of tumor of each pathway of spread. This is a patient with newly diagnosed pancreatic adenocarcinoma. The tumor is here. It's encasing the superior mesenteric artery. It has mass. It's occluding the superior mesenteric vein. And also this is a transverse duodenum. So it's directly invading into the adjacent structures. And it also spreads into the subperitoneal space, which is something that's a concept that's not widely known, but it's been published. So basically, peritoneal cavity, there are two spaces in the abdomen. One is a peritoneal cavity, what we think as and the second space is the subperitoneal space. So the peritoneal cavity is very minimal, like potential space between two linings of the peritoneum. All the organs are basically in the subperitoneal space. And these two are kind of exclusive spaces. And you can read this article on subperitoneal space. So the tumor the subperitoneal space is the extraperitoneal space. Basically, all the nerves, mesenteries, ligaments, lymphatics, everything is in this, and the organs are all in the subperitoneal space. So there is the reason I'm talking about this is there is a distinct pattern of spread. The peritoneal spread, it just goes along the fluid pathways. Whereas subperitoneal spread, it goes along the nerves, the mesenteries, or any ligaments. And sometimes this subperitoneal spread can breach the peritoneum, and that's the transperitoneal spread. And from there, it can cause drop metastatic deposits, drop pleural peritoneal implants. So just a distinction between those two, not that we can find on imaging, like If you see peritoneum is only single layered organ. So it's hard for us on imaging to say this is peritoneum or not, but the pattern of spread, peritoneal drop metastasis, they go into dependent areas. That gives us a difference between, tells us the difference between transperitoneal, subperitoneal spread and peritoneal spread. So this is another schematic showing how the peritoneal spread looks like, whereas subperitoneal spreads along the vessels, mesentery, and nerves. And then another example of direct tumor spread is like sometimes we see perineural spread. So the tumors try to, I think it seems, or like looking at all these cases or interpreting all the cancer imaging studies, it feels like tumors can spread via any space they can get into. So via lymphatics, via nerves, via vessels. So this is an example of direct tumor spread, but the nerves along the tumor, there might be potential space and the tumors kind of spread along them. So this is a patient with squamous cell carcinoma of the cheek, and there is a perineural spread along the inferior orbital nerve, pterygopalatine fossa, and also foramen rotundum. So these are all like from different areas, you're seeing similar patterns of spread, right? This is a pediatric patient with anaplastic nephroblastoma. So that was diagnosed and treated approximately 2 years back. And the patient was diagnosed with new lung metastasis. So what we see here is obvious, like the lung metastasis is obvious. And we also see that it's reaching the pleural surface. So what was not noticed at that point was this peritoneal drop, the pleural drop implant. It's in the dependent pleural space. This was missed at initial interpretation, and at thoracoscopic surgical resection, they found it. But for some reason, they only biopsied it. On the follow-up study, there was definite growth of this lesion. So something to keep in mind, when the tumor reaches the linings, it has the potential to involve the pleural or peritoneal linings, particularly the pleural. I've seen some cases once that involves the pleura, it can spread down reaches the pleura, it can spread down and cause drop metastasis. This is another patient with intraperitoneal spillage, but this patient has a ventricular peritoneal shunt catheter. This is an 18-year-old who had a pineal germ cell tumor resected about a year back. He was treated. He was fine, but a follow-up study a year later for abdominal pain, it showed all these tumor nodules in the peritoneum. The key to identify that it could be transperitoneal spread is basically questioning. Basically, every time you read a study, if you question yourself, okay, where did this come from? What is the organ of origin? Then you can, like, this is a VP shunt catheter, then we can try to figure out, like, could this be where VP shunt catheter spread? So it's always important to ask the question, where did this tumor come from and where will it go next? There was no recurrence on the MRI of the head, but the patient developed peritoneal recurrence. And the next pattern of spread is the lymphatic. So the lymphatic pathways, this is a patient with thyroid carcinoma, 9-year-old with papillary thyroid carcinoma, see large primary tumor mainly in the right, but there's multifocal disease. There's also like multiple lymph nodes. So the tumor has spread to the lymph nodes. And what happens after that is, so all these lymph nodes finally drain into the thoracic duct or right lymphatic duct. And then ultimately they give rise to the lung metastasis. So this patient had lung metastasis. So every time, sometimes when we see tiny nodules, we keep questioning, is this something tumor or not? So when you know that these can drain, like, we have to follow them carefully. It may not be possible to characterize them on the first study, but looking for them carefully and then pointing them out and following carefully, the follow-up studies will help. So this is one nodule seen at diagnosis, and then at 3 years later, I mean, this tumor spreads very slowly. So these nodules have increased very slowly in size over a period of 3 years. So another concept I want to talk about is the retrograde. We all know about antegrade lymphatic dissemination. So this is a testicular tumor, ultrasound showing a mass in the right testis, and then so this is this is a very well-known site of drainage. The testicles drain into the retroperitoneal nodes around the level of the renal vein insertions, like wherever the gonadal vein inserts into the IVC around the level of renal vein. On the left side, it inserts into the left renal vein. So we all know that. So these nodes are in the typical distribution of testicular cancer. But these nodes here, all these. So sometimes so these nodes are also enlarged. And what has been described is like when the antegrades lymphatics are obstructed, they can always spread whether obstructed or not. But usually when they are obstructed, they can spread retrogradely. So that is one pattern that we don't usually think about, the retrograde nodal spread, that I want you to familiarize you with. This is antegrade. So similar to retrograde lymphatic dissemination, retrograde hematogenous dissemination can also occur. Sometimes there may be obstruction, sometimes there may not be obstruction to the antegrade flow, but usually you'll see, I think it's like the most common pathway is antegrade spread, but retrograde spread also you see from time to time. And that's when things don't make sense, then you have to think, but we can most of the times we can explain why the tumor spreads to some reasons, some places. So here, this is the right retroperitoneal sarcoma. This patient it shows mass effect on the adjacent IVC. It's slightly narrowed, and the patient presented with lung nodules. So these lung nodules were detected, but this one was not identified at diagnosis. The patient had surgical resection of this mass. The lung nodules were followed. So these grew on around the time between surgery, I think. These lung nodules grew on follow-up studies. And even this retrograde spread. So the IVC is connected to all the draining, like intercostal or lumbar venous plexus, and then it goes into the psoas muscle here. This psoas muscle is a retrograde metastasis, is a retrograde hematogenous metastasis. Another example of retrograde hematogenous dissemination, this patient has IVC occlusion from retroperitoneal paraganglioma. And then this patient never developed lung metastasis. Usually you expect lung metastasis to occur before anything else, but this particular patient did not develop lung metastasis, but due to IVC occlusion, there was more retrograde spread. And then there is tumor in the spine. There's spinal metastasis with epidural component. So this is all spread by the retrograde dissemination. This is another patient. So this here we can see, as I was alluding to earlier, like tumor tries to find any pathway that any tubes it can to spread. So this is that example. Like this patient had hematogenous spread initially. This is a patient, 11-year-old girl with osteosarcoma. The osteosarcoma, it progressed on initial chemotherapy. So there was a skip lesion, but what we could not identify at that point was there were multiple small veins. So the tumor, osteosarcoma, has a tendency to go into the veins. So it was filling up all these small veins going from the tumor. And then there's also a skip lesion. So here, and then I want also to familiarize with this concept of like intravascular metastasis. So these tumor emboli, since we know the patient has multiple tumor thrombi, these tumor emboli, when they first start out, the osteosarcomas, they appear as dilated beaded vessels. From there, before the development of round overt metastasis that we are all familiar with, you can have this appearance of beaded vessels. It's not just limited to osteosarcoma. I have seen in other cancers also, renal cell carcinomas. So any sarcomas do the same thing. So, but identifying this dilated beaded vessel is one of the earliest signs of lung metastasis. This is still tumor in the distal pulmonary vessels, and then it kind of maybe breaches out of the parenchyma. So this patient also, in addition to what we know at surgery as multiple tumor emboli in the small veins, patient developed a small embolus here in the right pulmonary artery. At 6-month follow-up. This pulmonary embolus, since I already knew the patient had tumor thrombi. We called it as tumor embolus, but there's always a potential for mistaking these emboli as bland emboli. But just to remember, just keep in mind that sometimes tumor emboli happen in tumors beyond hepatocellular carcinomas or renal cell carcinomas. And what happened after that is, over a period of time, you see emboli, I guess they develop metastatic disease. So this is a metastatic disease in the right upper lobe. And over a period of time, so we all know that osteosarcoma spreads hematogenously, right? Over a period of time here, maybe from the lung, it found some other channels, lymphatic channels. So it spread through the lymph nodes. And now you see hilar node, subcarinal node. So they are not exclusive. In the beginning, you find sometimes like some tumors spread hematogenously exclusively. But as the tumor kind of spreads more and more, they just try to take any pathway they can spread. So this is another patient, again, some kind of mixed, in that context of mixed spread. So this is a patient who had resected colon cancer, again, a 16-year-old with bilateral drop metastasis in the ovaries. She developed about 1.5 years later ovarian metastasis. And these ovarian metastases were resected, both ovaries were resected. And then 1 year after resection, the patient developed lymph nodal metastasis, like how a primary ovarian tumor. If it's a primary ovarian tumor, you would expect mass nodes in the retroperitoneum. So this is, metastasis also follow the same pathways of spread. If you know something, if you know how primary tumors spread, metastasis also take the same pathways of spread. So this patient, sometimes we can gauge the aggressiveness of the tumor, not only by the extent of disease, but also by the multiple pathways it takes to spread. At initial diagnosis, this is a 32-year-old woman with stomach cancer. These are all the baseline studies. And you see the primary tumor is thickened, like stomach wall is thickened. And then there's extensive lymph nodal involvement around the celiac axis. And not only there is extensive antegrade nodal involvement, there is retrograde nodal involvement here, common iliac veins, iliac nodes, external iliac nodes are involved. And she also has peritoneal drop metastasis, both ovaries are enlarged. And the antegrade spread of lymphatics, now it's involved it spread to all the nodes in the thorax, and also there were multiple lung nodes, the lung metastasis from the nodal drainage into the through the lymphatic ducts, thoracic duct into the lungs. So seeing these multiple pathways, we can, not only by the extent of disease, but multiple paths of involvement, we can say this is very aggressive disease. And this patient did not survive longer. So one of the schematic to illustrate the same thing. So how does lymphatic dissemination? This is about antegrade lymphatic dissemination. Head and neck tumors go to cervical nodes, mediastinal hilar nodes, celiac, mesenteric for the gastrointestinal tract, and then internal iliac, external iliac, retroperitoneal nodes, cisterna chyli, thoracic duct, extremity, skin or breast lesions. They also finally reach the lymphatic duct. And then this is the junction, the thoracic duct and lymphatic duct. This is the major lymphatico-venous communication that exists in the body, but other smaller lymphatico-venous communications have also been described, but it's hard to find the literature on them. But this is the major one. So the lymph nodal spread and hematogenous spread kind of blend in at this point. They drain into the junction and then into the heart, from right heart into the lung, and then they can, from lung, it can go to systemic dissemination. And this is a schematic dissemination for the hematogenous dissemination pathway. So again, head and neck tumors, if they're spreading directly through the draining veins, they can reach SVC and right heart. But there's also another pathway called vertebral venous plexus. So all the vertebral, like from every part so I'll come to the vertebral venous plexus in a minute, but so you can see like lungs, bronchial veins, the pelvic plexus, the intercostal veins, everything can also reach via alternate pathway, which is vertebral venous plexus pathway. The lung, bronchial and intercostal lungs, if it drains through that, it reaches the lung again. But if the lung cancer drains via pulmonary vein, if it's a primary tumor or lung metastasis, if they drain via pulmonary vein, they result in systemic dissemination. Whereas GI cancers, they go to the liver first, most of them, and then they go to the hepatic vein and then go to the lungs. And from there, they reach the systemic dissemination. The other cancers that drain directly go like GU cancers, like renal cell carcinomas, they go to the lung directly from lung. After lung, once they reach the pulmonary vein, they disseminate systemically. So I just want you to understand these differences, like the initial drainage pathways, they culminate either in liver. For some tumors, they culminate in lung. For some tumors, it is bone. And from lung, they can go anywhere in the body, like entire systemic dissemination. So these are the slight nuances in the dissemination pathways. And this is the vertebral venous plexus I'm talking about. It's a continuous valvulus system of veins that connects with the IVC, azygous veins, that's interconnecting with all the veins, intercostal veins, the cervical veins, pelvic veins. So that leads to this thing is convergence of pathways of tumor spread. So as I was showing before, primary tumors, local recurrence, and metastasis, they all spread via the same basic pathways. Most tumors metastasize to few initial sites. Do you have any questions? I'm hearing some background. Okay.
Go ahead, please. Go ahead.
Okay. So most tumors metastasize to few initial initial sites, which are liver, lung, and bone. And then primary or secondary tumors in the liver and bone further disseminate to lungs. Primary and secondary tumors in the lungs can potentially disseminate anywhere in the rest of the body. Then the other thing we need to remember is like they not only, the liver, lungs, and bone act not only as initial sites of metastatic disease, but there is they can act as a temporary barrier to systemic dissemination, right? To further spread of disease. They need to lodge all the cells that are spreading, the tumor cells need to lodge in those organs, grow into overt metastasis, or then find pathways to spread further. So there'll be slow, you can see these temporal evolution of metastasis over a period of time, because there is some tumors may have some time to before they spread to every part in the body. And exceptions to the general pathways. Most of the times you see like a serial progression of these metastatic disease from one site to the next site to the next site. But there are exceptions. I mean, they occur. And the explanations for these exceptions are sometimes there may be paradoxical tumor embolism, in which tumor embolus can bypass the pulmonary circulation via either via patent or foramen ovale. And then the vertebral venous plexus also, it's like, what if tumors should first see, I mean, we should first see most of the times, like renal cell carcinoma first mostly goes to the lungs, but sometimes you see bone metastasis first. And that is because of these diversion of blood flow into the vertebral venous plexus, venous system. And I mean, even minor chips, like changes like intrathoracic and intra-abdominal pressure changes, variations can may result in the dislodgement of the tumor emboli into the retrograde spread. And then when antegrade spread is impeded, also you see retrograde spread. And rarely, another mechanism that has been proposed is sometimes the tumor's cells can go past the first capillary bed or without being arrested. So they can directly spread without getting arrested there. So far, I think Everybody knows the basic pathways of spread. The unfamiliar concepts that I have introduced probably are like subperitoneal spread, lymphatic or venous communications. Like we know them, but we don't use them that much. We all know that the thoracic duct drains into the junction of SVC and IJV, but we don't think about lung metastasis after that frequently. And then retrograde lymphatic dissemination, retrograde hematogenesis dissemination, vertebral venous plexus. So these two, retrograde lymphatic and hematogenous, we don't think very often. This is something that I've learned over the course of years while researching for this topic and writing this manuscript. And then we started, the more I know, once I know this thing, I started finding examples of the cases. So I think they are there everywhere. Once we start looking for them, we'll find more and more cases. Vertebral venous system, we all know that the prostate tumor spreads via vertebral venous plexus, pastance venous plexus, but beyond that, for every other tumor, we don't use it that often, but this is also one thing for us to keep in mind in our search patterns. So why did, so what is the importance of this? Like what, I'm just going to show some missed and misinterpreted cases. So that tells us why we need to understand, why all radiologists need to understand these concepts. This was an unfortunate patient with osteosarcoma. These are the current study kind of thing. So this was somehow misinterpreted as liver metastasis. And the patient received, this is a patient with osteosarcoma, extraskeletal osteosarcoma, and who had known lung metastasis. But at this point, this study, who had known lung metastasis, the primary tumor was resected, the lung metastasis was resected. This was the only site of disease at that point. So this patient underwent hepatic arterial chemo infusion because they thought it was read as a liver metastasis, and for 2 cycles. And even the IR note mentioned that there was no blush, but we still went ahead and gave it. So something, but if we understand the pattern of spread, these are the studies 2 months before the CT in A and B. If you understand that, so there is a subtle lesion. So this, and if we go back further, this lung metastasis has reached the pleural surface. And then it resulted in drop metastasis in the deep costophrenic sulcus, which has grown. So they probably, if we know that we understand the pattern of disease, there's no way you can call this as liver metastatic disease. And we would have saved the treatment, saved some invasive procedure for this patient. Whatever chemotherapy that was given intraarterially was like as effective as intravenous chemotherapy. So there are real world implications to what we say and what we don't say in our reports. This is another patient with missed lung metastasis. So this is a patient with clear cell renal cell carcinoma. The patient had resection of the primary tumor. He had radical left nephrectomy, adrenalectomy, and splenectomy for his primary tumor. So he only has one adrenal gland. And during the follow-up study, we noticed this right adrenal metastasis. So realizing, I think, and these tiny lung nodules, these were not identified, and there was this very tiny right hilar node. Even it's hard to know all these, but once you know that renal cell carcinoma typically spreads to lungs before going into the contralateral adrenal gland. If it is the same adrenal gland, sometimes it may do like direct infiltration or something like that. But contralateral adrenal gland, you should see lung metastasis typically before. So we could have paid more due diligence and characterize these lung nodules. We went back and say, if we could see these were not there on remote prior studies, maybe we would not have called it as a solitary metastasis, but this was called as a solitary metastasis. And the patient underwent adrenalectomy, right adrenalectomy. So this patient now is on lifelong adrenal hormone replacement. And on the follow-up, we can see the lung nodules increasing. and the right hilar node is increasing. Maybe it would, if we know that, if they had they known that, maybe the treatment would have been systemic chemotherapy rather than doing an adrenalectomy for this patient. And those are the real world implications on what we say and what we don't say. This is a patient with, so here, this is a patient with newly diagnosed colon cancer, 43-year-old. There's in fact ball wall thickening. This patient did not have any liver metastasis, but only thing that was seen was this mass here in the subcutaneous soft tissues in the chest wall, infiltrating the chest wall. So this was called as metastasis, but understanding that the rectosigmoid colon cancer first goes to the liver, or sometimes if it is lower rectal cancer, it can go to the lungs. But without seeing either of these, this is kind of atypical, and questioning that it's an atypical location would have prompted biopsy. The patient had biopsy anyway, and this was a melanoma. So at least the radiologist would have scored some brownie points if we called it as atypical. So this is another thing I want I want all of you to understand, like something like that's one of the key take-home messages of my lecture is this thing. How do we characterize lung nodules? Can we characterize lung nodules by assessing temporal evolution and correlating with tumor treatment history? So this is a patient with colon cancer, and this nodule was seen at baseline. So at baseline, lung and liver lesions, we see tons of, we sometimes see small liver lesions, small lung lesions, and it's impossible to characterize them on one study. But if we correlate them with treatment history, so we should be able to characterize, if we correlate them with treatment and then look at them on the follow-up study, we should be able to characterize most of the studies. So this at baseline, this was a small round cavitary lung nodule, which has become smaller. And I'm not sure if it is projecting well, but it became very cystic. And then at this point, the patient had also had liver metastasis. So these liver metastases are becoming smaller, more well-defined. And after this 16-month follow-up, the liver metastases were resected. The lung nodule, I think initially it was questioned, and then after that it got lost. Nobody bothered about it. And then over a period of time, once the patient is off chemotherapy, you see tiny peripheral nodules growing slowly over a period of time. Even here, it was not picked up or called as a metastasis, but once it became this, at this time point, it was called as a metastasis. So we have an opportunity for improvement. We need to correlate our images with the treatment history and see how they evolve over time. So if we understand treatment history, then we would have diagnosed maybe at this point, if not here, or sometimes much earlier. So this again, so this is an example of how to characterize a lung lesion. Similarly, a liver lesion, how to characterize subtle liver lesions. This is a patient with colorectal liver metastasis. So this big liver metastasis, we can easily characterize. There's no question about that. But the patient, and in our hospital, like they resect any resectable colorectal metastasis, they resect them. Patient also has this subtle liver lesion. This is the pre-contrast at baseline, pre-contrast, and then this is a portal venous phase. And there are some cystic lesions. So all these patients, we frequently see like cystic lesions in the liver, and it gets challenging to know whether cystic lesions are actually treated a tumor versus like cystic implants if the patient has mucinous tumor. So the way to characterize, one way is you can look at triple phase studies. The pre-contrast size is bigger. With contrast, they kind of slowly enhance, and then on the delayed, they become much smaller. So that is one way of doing it. And the second way is, comparing with treatment. So this lesion has improved with treatment, and this almost disappeared here or became smaller. So while this cystic lesion, nothing changed on treatment. So this is an actual cyst, simple cyst, but this tiny lesion is actually a metastasis that is responding to treatment. So Just to keep in mind that we can characterize like a subtle liver lesions by subtle lesions by correlating the temporal evolution, by correlating the temporal evolution and treatment history. Another patient with temporal evolution, I mean, how we can use temporal evolution and understand the spread. So here, there's a patient has a renal cell carcinoma, clear cell renal cell carcinoma. At baseline, the patient presented with metastatic disease in the lungs, nodes, and also mediastinal nodes, and also bone metastasis. So he has these multiple lung metastasis. And what I wanted to show is these intravascular metastasis that I was talking about, dilated and beaded appearance. So at baseline, and the patient progressed with frontline chemotherapy. So you can see much more nodularity. But the next chemotherapy worked miraculously, and all this nodularity has disappeared. So not only like it's important to understand that beaded appearance is a feature of metastatic disease, but also like this responding to treatment is one thing. And this response correlates with the response. Like here, these nodal metastases have increased at the same time with this, but now with the second line chemotherapy, everything resolved. And then this is another patient here. How can we use this knowledge to distinguish when there are two primary tumors where this liver metastasis is coming from? So this this is a 65-year-old with history of cecal adenocarcinoma 5 years back and a new anal carcinoma. So they wanted to know if this liver metastasis is originating from the remote history or remote cancer or new cancer. So this tumor here, anal carcinoma, was a squamous cell carcinoma, and it typically spreads locoregional lymph nodes to the inguinal nodes. Without spreading to the lungs, and this patient did not have lung metastasis. It's hard for, it's not typical for this squamous cell carcinoma to spread to the portal circulation, to the liver. So we hypothesized, at least this patient, we said that this could be the liver metastasis from the cecal cancer, cecal adenocarcinoma, and that was correct. So we can use our understanding of the patterns of spread to characterize which is the likely site of primary tumor. And this is a patient with unknown primary. And looking at the pattern of the spread, sometimes we may be able to predict where the primary tumor is coming from. So these are baseline PET CT images from a 64-year-old patient with newly diagnosed masses in the left hilum and bone and soft tissue metastasis. So based on the distribution, solitary mass in the lung, a node, and then widespread dissemination, you can say this is lung metastasis. Unfortunately, the pathology did not show it was a undifferentiated carcinoma, and the pathologist did not confirm it as a lung cancer. But I think based on the pattern, we have a role to play that we can say it is from lung cancer. So this is one of the take-home messages that I want to leave with you is this thing. A lung nodular liver lesion that responds to chemotherapy synchronous to primary tumor and/or metastatic disease is more likely to be metastatic disease. And conversely, we see a lot of lung nodules and we don't know what to do with them. Or liver cysts. These lung nodules are liver lesions that remain stable during chemotherapy, while other sites are responding or progressing, is more likely to be benign. And also something to remember, that subtle growth in a lung nodule that has during a break in chemotherapy, break in treatment, is likely to be malignant and should be recognized and followed closely. So the next part, I'm going to talk about the new proposal. So for metastatic disease, I'm going to convince you, I hope I'm going to convince you that we cannot just live with M0, M1 for all the cancers anymore. Like patients with metastatic disease are living longer. And most of the AJCCs, AJCC is coming up with some subcategorization of metastatic disease for some tumors, but like T stage and N stage, it's not uniform for across the tumors. So for T stage and N stage, increasing T number or N number of the TNM classification means increasing extent of the disease and increasing distance from the tumor. For M metastatic disease, it's not like there are some subcategorizations of M stage, but they don't necessarily imply that the tumor is farther. So that's why we are proposing a new subclassification. So here, I'm going to show 5 examples to show the differences between different tumors. This patient has colon cancer. As we all know, it spreads to the liver directly. And this patient also developed local recurrence at the anastomotic site. And then that spread to the nodes, retroperitoneal nodes, and over a period of time to the portocaval node. And then from liver cancer, from the liver mets over a period of time, they spread like about 9 years later, lung metastasis. And then around the same time, bone metastasis from further spread of lung. This lung metastasis has, I think by this time, because of it spread very fast. And also the patient developed brain metastasis. So from diagnosis, it took about 9.8 years or almost 10 years for the patient with colon cancer to develop brain metastasis. Most patients may not survive this longer, but there are some patients who survive this longer. And we need to keep in mind that once these patients develop lung metastasis, they are at risk for systemic dissemination to bones, brain, or anywhere else in the body. This is a patient with osteosarcoma. This is a rib osteosarcoma in a 21-year-old patient. So this patient developed lung metastasis at presentation. So the venous drainage of these ribs will be going into the lungs. And so this patient had lung metastasis at diagnosis. And then these lung metastasis, like you can see, like I didn't show the left lower lobe metastasis, but it was going directly along the left inferior pulmonary vein. And from this point, if you see these like train tumor going into the pulmonary veins, then you have to raise the possible, like these patients are at risk for systemic dissemination now. So about 2 years, 10 months later, the patient developed brain metastasis. Initially, it was oligometastatic disease. She was treated. There were multiple recurrence. There was recurrence of the brain metastasis. And there's another node here, like over a period of time, the systemic disease progressed. So this thrombus here, it was reaching the left atrium. There was another right lower lobe metastasis also reaching the left atrium. And there's further systemic metastatic disease to the lungs, to the liver, to the kidney. And this also is going it shows tumor thrombus going into the left renal vein. So this patient survived about 4 years, but I think systemic dissemination started around 2 years. And compared to the lung metastasis, which has a direct highway access to the systemic dissemination. So the lung primary tumor. So this is a patient with lung primary tumor. And this patient started with systemic dissemination to the brain and bones right at presentation, subcutaneous soft tissues. So the lung cancer, if it drains via pulmonary veins, and I think this patient died within 1 year. So the lung cancer is very aggressive because of that reason. And I also want to, so sometimes we say that the primary tumor, like the biology of the tumor depends on the primary tumor, right? The histology of the primary tumor. But regardless of the histology, sometimes these anatomic pathways are the ones that dictate where the tumor spreads. So this is a kid, a 2-year-old boy with the pleuropulmonary blastema. And this patient developed brain metastasis within 5 months, similar to how a adult lung cancer spreads. These patients are known, the pleuropulmonary, common sites of metastasis for pleuropulmonary blastema also include bones. So brain, bones, so they spread systemically. Similarly, this is another patient with a child with 16-year-old with alveolar rhabdomyosarcoma of the prostate. So I don't need to show anyone how the prostate tumor spreads. It spreads via vertebral venous plexus to the bones and then lymph nodes. So the same pathway of spreads is seen in these patients too. So here, this is a primary tumor involving the prostate, and then these nodes, locoregional nodes, and then this patient has extensive bone metastatic disease, and these nodes ultimately have spread to the lung. There are nodes in the mediastinum. So regardless of the histology, anatomic of like these, and the age of the patient, the pathways of the spread are the same. So the proposal we have made for subcategorization of metastatic diseases, M0 is no metastatic disease, M1 is the first initial site, liver, bone, peritoneal disease, when they present as initial sites. And then M2 is lung metastasis, M3 is systemic dissemination. The systemic dissemination can include all these sites, but we just have to make an assessment like whether it is systemic dissemination at that point or not. So in conclusion, careful assessment of serial imaging studies in conjunction with treatment provides valuable insight into the temporal evolution of spread of tumors, the pathways involved in the spread, tumor growth rate, aggressiveness of the tumor, and response to different treatments. And I encourage you to get answers. Like while interpreting studies, I encourage you to find an imaging approach that answers where the tumor came from, where it will go next, if it follows the basic pathways of tumor spread. And this can potentially lead to early diagnosis of tumor spread. And also, if the suspected lesion at a particular site does not follow known pathways of tumor spread, you should question it as question that lesion. And maybe it's a good idea to get a biopsy. And also actively seeking out retrograde pathways of retrograde venous and lymphatic spread is also one good thing, and also search pattern that I would encourage you to develop. Okay. So in the end, thank you for your attention. I would like to present a poem by my daughter. I'm sorry, I don't know.
Thoughts about Earth. The Earth is like a giant tree. All the other trees in the solar system envy her because they cannot grow their bright green leaves, the great broad trunk, or even make homes for such lively animals. They can only watch, but what do we think about Earth? We think she's an inanimate object that has no value. We think we have the right to use her however we want. We don't see the price to it. We act like we don't care about her. We act like we only care about riches and beauty, but the only riches and beauty that matter are Earth.